Welcome back to the deep dive. Today, we're getting right into a really core topic for anyone in clinical practice looking after aging skin and mucous membranes. We're drawing from Chapter 17 of Basic Geriatric Nursing.
Exactly. And our goal here is pretty straightforward. Give you a quick, solid understanding of the key changes, the assessment tools you'll need, and the essential nursing care for the skin and mouth in older adults.
Okay.
Because honestly, these areas, they're like windows into the patient's overall health. Think nutrition, circulation, metabolism. It also shows up here first.
Right, frontline indicators. So let's start with the basics of aging skin. What's the big structural shift that makes it, well, so much more vulnerable?
It really comes down to the structure itself changing. Imagine the outer protective layer, the epidermis. It gets noticeably thinner.
Thinner, okay.
And maybe even more importantly, that subcutaneous padding, the natural cushion underneath it, just decreases, less fat there.
Ah, I see.
So that combination, it makes older folks really susceptible to injuries like skin tears, which are super common and painful, and of course the big one, pressure injuries.
Pressure injuries, yeah. Huge issue. And you mentioned some specific terms we need to get comfortable with.
Yeah, definitely. Well, we talk about pruritus. That's the clinical term for really persistent, bothersome itching.
Artists, got it.
And xerostomia. That's basically chronic dry mouth. Both sound kind of minor, maybe, but they can signal deeper problems and really impact quality of life.
Okay, let's dive into those skin changes first. Beyond the obvious wrinkles, what's happening physiologically that ups the injury risk?
Fragility is like the key word. Bruising happens way more easily simply because the tiny blood vessels, the capillaries, just aren't as strong.
Makes sense.
And you also have to think about medications. Steroids, for instance, can make skin generally more fragile, more friable, and anticoagulants. Even a small bump can lead to significant bruising or bleeding.
Right. But you mentioned dry skin earlier. The book says something like 75% of people over 65 have it. That's not just discomfort, is it? It sets the stage for skin breakdown.
Absolutely. You've got less oil production from sebaceous glands, maybe some circulatory changes too, and that leads to that classic dry, sometimes scaly skin, especially on the legs.
Mm-hmm.
But the really crucial safety point here is the change in sensation. The receptor cells in the dermis, their function decreases.
So they feel less?
Yeah, less touch, less heat, and critically less pressure. If you don't feel that pressure building up on your hip or your heel when you're sitting or lying down,
You don't move.
exactly, you don't shift your weight. And that's a direct line to developing pressure injuries.
Yeah.
The risk just skyrockets.
Wow. So less sensation means higher risk of breakdown. And you mentioned temperature regulation issues too.
It's this really tough situation, that loss of subcutaneous fat. It means they genuinely feel colder more easily. So hypothermia is a real risk, especially in cooler environments. But at the same time, their sweat glands don't work as efficiently. So when it gets hot, they struggle to cool down. That puts them at risk for hyperthermia. It's a double whammy, really.
So you need to be really mindful of the environment for them.
Definitely. Proactive management is key.
Okay, so the skin's changing dramatically. I'm guessing hair and nails follow suit. What do those changes tell us?
They absolutely do. They reflect aging, hormonal shifts,
Mm-hmm.
the whole systemic picture. You see graying hair, obviously that's less melanin production.
Right.
And just general thinning is common as hair follicles kind of go dormant. Hormones can also cause shifts like sometimes more facial hair in women post-menopause.
Okay. But what's the clinical red flag with hair?
The big one is sudden or really excessive hair loss. The term is alopecia. If you see that, it's not just cosmetic. It often signals something systemic going on, maybe a nutritional deficiency, an infection, thyroid issues, something like that. He's looking into.
Gotcha. Alopecia, stomach check. And nails. You mentioned thickening.
Yes, hyperkeratosis,
Mm-hmm.
especially the toenails. They can get really thick, hard, and sometimes discolored. Fungal infections love that environment too.
Mm.
But the really serious safety concern, especially for anyone with diabetes or poor circulation,
Mm.
it's those severely overgrown curling nails, sometimes called ram's horn nails.
Ram's horn nails, that sounds painful.
It is. They can curl right under the toe, causing intense pain, making it hard to wear shoes, hard to walk, which then increases immobility risk, circling back to pressure injury risk.
It's all connected.
Totally. And the source material is crystal clear on this. For these high-risk folks, professional podiatry care is essential. They should never try to cut thick nails or treat their own corns or calluses with, like razors or scissors.
Why not? Infection risk.
Huge infection risk,
Mm.
especially with diabetes where healing is impaired and sensation might be reduced. A small cut can become a massive infection, potentially leading to amputation. It's a profound risk we have to prevent.
That's a really vital piece of safety advice. Okay, let's pivot to specific problems and how we assess for risk. Dry skin leading to that intense itching, pruritus.
Yeah, that itching can be incredibly disruptive. Affects sleep, social interaction.
Yeah.
It's not trivial. And always be alert for rashes. If a rash pops up shortly after starting a new medication,
A suspect an allergic reaction.
first thought, hold the drug, notify the provider immediately. That's standard procedure.
Okay. Any specific infections that are like extra tricky to spot in older adults?
The book highlights scabies. It's caused by a tiny mite, Sarcoptes scabies.
Right.
But it's tough because the incubation period can be long 4 to 6 weeks, and they might have no symptoms during that time. And in older adults, presentation might not be typical. You're looking for these faint, dark, wavy lines, often on the wrist, between the fingers. Very subtle sometimes.
And it spreads easily.
By direct contact, yeah. So in any facility setting, early detection and careful precautions are absolutely crucial to prevent outbreaks.
Got it. Okay, moving to skin color changes. We all know about age spots, but the source really emphasizes changes in moles. Why is that so critical?
Because any change, size, shape, color, border irregularity, even just a different sensation in an existing mole could signal a precancerous lesion or an actual skin cancer like melanoma.
So not just cosmetic.
Definitely not. This is potentially life-saving screening. Any suspicious change needs immediate reporting and follow-up.
Okay, so we've talked about fragility, specific issues. Let's really focus on pressure injuries now. PIs. The source says they result from pressure plus shearing forces. What are shearing forces again?
Think about someone sitting up in bed. If the head of the bed is raised high, gravity pulls their body down, but their skin might stick to the sheets for a moment.
Oh, okay.
That causes the underlying tissues and capillaries to stretch and tear internally. It's not just direct pressure, it's that dragging, stretching force too. That combination cuts off blood supply ischemia, leading to tissue death, necrosis, and breakdown.
Devastating. And given how common PIs are and the liability involved, assessment has to be formalized, right?
Absolutely mandatory. We listed so many risk factors earlier. Poor nutrition, being immobile, incontinence, obesity, edema, cognitive issues.
Yeah.
You can't just eyeball it. You need standardized tools.
Like the Braden scale.
Exactly. The Braden scale is widely used. It looks at 6 specific things. Sensory perception, can they feel pressure? Moisture, activity level, mobility, can they change position? Nutrition and friction and shear.
And it gives a score.
Yep. You score each category, and a total score of 16 or less generally flags that patient as being at high risk for developing a pressure injury.
So it forces you to quantify the risk.
It does. The Norton scale is another one, slightly different categories. Physical condition, mental condition, activity, mobility, incontinence, but the same principle. Use a validated tool, get an objective score, and then you must implement a prevention plan based on that score. It's proactive care.
And there's a really important point about assessing dark skin for stage 1 PIs, isn't there? Redness might not show up.
Critically important point. That classic redness of a stage 1 injury often isn't visible on darkly pigmented skin. You need good lighting, preferably a halogen light, and you might see a purplish or deep blue hue instead.
So color isn't reliable. What do you rely on then?
Palpation. You have to touch the skin over bony areas. Feel for changes in temperature. It might feel warmer or cooler than the surrounding skin. Feel for bogginess, like localized swelling or edema, or unusual firmness or hardness. Your fingers become your eyes in this case.
Palpation is key for dark skin assessment. Got it. Okay, so we've identified the risk using these tools. What does the actual care plan look like? Let's talk bathing and keeping skin moisturized.
Right. Since dryness is a major enemy, we often need to reduce how often we do full baths or showers. Maybe only once or twice a week is enough, with partial sponge baths in between.
And the type of soap matters.
Hugely. Use mild, non-detergent, non-perfume soaps. Rinse really well. And crucially, pat the skin dry, never rub vigorously.
Pat, don't rub. Okay.
And then moisturize, moisturize, moisturize. Use emollients, creams. Petrolatum-based ointments tend to last longer and provide a better barrier. Apply them frequently.
Avoid.
Definitely avoid lotions with alcohol. They might feel cool initially, but they actually dry the skin out more in the long run.
Good tip. Okay, what about incontinence? Massive risk factor.
Massive. The key is prompt cleansing after any episode of incontinence. Urine and feces are incredibly irritating to fragile skin.
So check frequently.
Very frequently. Cleanse gently but thoroughly and immediately apply a barrier ointment or cream to protect the skin from the next exposure. If using absorbent pads or briefs, Make sure they're the type that wick moisture away from the skin, not trap it against it.
Got it. Protect the skin proactively. Now let's talk positioning. How do we manage pressure and shear in bed or in a chair?
Rule number 1, move them often. The absolute maximum time anyone at risk should stay in one position is 2 hours. Often it needs to be more frequent than that.
2 hours max. Okay.
And when they're in bed, be really careful about raising the head. Keep it at 30 degrees or lower whenever possible.
Why only 30 degrees?
Because anything higher significantly increases those shearing forces as they slide down. It puts immense stress on the sacrum and heels.
Right. And when turning them side to side?
Use a 30-degree lateral position. Don't roll them fully onto their side, like 90 degrees. That puts direct pressure right on the hip bone, the trochanter. A 30-degree tilt, often using pillows or wedges for support, keeps pressure off those main bony points.
30 degrees tilt, not full lateral. Okay. Now, what's the really crucial thing the book says not to do if you find a reddened area?
This is so important and sometimes feels wrong, but you must not massage the reddened area.
Really? Wait a minute.
Because that tissue is already stressed, blood flow, and compromised. Massaging it can actually increase the pressure and friction, further damaging those fragile capillaries and potentially making the injury worse, accelerating breakdown. Just observe it, document it, and relieve pressure from it.
No massage on red spots. Got it. And when dealing with open wounds, actual PIs.
Strict aseptic technique, sterile technique usually, prevent infection at all costs. And avoid harsh cleansers like hydrogen peroxide or povidone iodine directly in the wound bed unless specifically ordered for a certain reason. They can actually damage healthy granulation tissue that's trying to form. Gentle cleansing with normal saline is usually preferred.
Makes sense. Preserve healthy tissue. And what about nutrition? How does that fit in?
It's fundamental. You can't heal tissue without the building blocks. Healing requires extra calories, and especially extra protein and vitamin C. Wound healing demands a lot nutritionally.
So nutritional support is part of the plan.
Has to be. And just circling back to feet for a second, daily inspection is critical. Teach patients or caregivers to look for any redness, blisters, cuts, changes, especially between the toes. And again, reinforce. No self-treating corns or calluses with sharp objects if they have diabetes or poor circulation.
Great summary on skin. Let's shift gears now to the mouth-oral cavity. The source calls it often neglected but vital. Why do older adults sometimes struggle with oral health?
Several reasons, unfortunately. Sometimes it's just not seen as a high priority compared to other health issues. Cost of dental care is a huge barrier for many, as is just getting to the dentist, transportation issues.
Yeah.
And then there are physical limitations. Arthritis can make holding a toothbrush difficult. Stroke might affect dexterity. Dementia can lead to resistance or forgetting care. It's complex.
And the consequences of poor oral health aren't just local, right? They affect the whole body.
Absolutely. Poor hygiene obviously leads to bad breath, halitosis, and gum inflammation, gingivitis. But untreated gingivitis can progress to serious periodontal disease.
Which means losing teeth.
Yes, tooth loss is a major outcome. But beyond that, there's growing evidence linking chronic inflammation from periodontal disease to systemic problems, things like cardiovascular disease, stroke, even potentially worsening blood sugar control in diabetics. That mouth-body connection is really strong.
Wow. And you mentioned xerostomia earlier, dry mouth. What causes that?
It's super common. Saliva production naturally decreases a bit with age, but dehydration is a big factor, and so are medications. So many common drugs taken by older adults, diuretics, antidepressants, antihistamines, sedatives, have dry mouth as a side effect.
And what does dry mouth do?
Without enough saliva to cleanse the mouth, buffer acids, and start digestion, chewing and swallowing become difficult and painful. This can impact nutrition. And the lack of saliva dramatically increases the risk for cavities and fungal infections like thrush.
So managing dry mouth is important. Okay, what are the serious red flags we need to look for inside the mouth?
Oral cancer screening is crucial. Look for white patches that don't scrape off. They could be leukoplakia, which can be precancerous. Any sore or lesion that doesn't heal within 2 weeks needs checking out.
2 weeks is the benchmark.
Yeah. Also, look for any lumps in the cheek, difficulty swallowing, or persistent hoarseness. Oral cancer is strongly linked to tobacco and alcohol use, and increasingly to HPV-16 infection.
Okay. Any other urgent alerts related to the mouth area?
Yes, a really critical one, jaw pain. While it can be dental, jaw pain, especially in women, can be an atypical symptom of a heart attack, a myocardial infarction, or MI. Never dismiss jaw pain without considering a cardiac cause. Needs careful assessment.
Jaw pain could be cardiac. That's a vital safety point.
Yep.
So, given all these risks, what's the bottom line for nursing staff providing daily care?
Prioritize it. Thorough oral hygiene needs to happen at least twice a day, minimum.
And how should it be done?
Use a toothbrush. This is key. Foam swabs those little pink sponges on a stick. They are not effective for removing plaque from teeth. They're okay for cleaning the gums and tissues in someone with no teeth, a dentulous. But for anyone with teeth, natural or dentures, you need the mechanical action of bristles.
Toothbrush for teeth, swab maybe for gums if no teeth. Got it. What about denture care?
Dentures should come out at night. Gives the gums a rest, prevents potential irritation or even choking hazards if they become loose.
Okay, how to clean them?
Clean them daily over a basin or a towel. Dropping them in the sink is a classic way to break them. Use a denture brush and cleanser. And really importantly, if dentures don't fit well, if they're causing sore spots or pain, the answer isn't just more denture adhesive.
No.
No, that signals a problem that needs professional dental assessment. Ill-fitting dentures can cause significant tissue damage and affect nutrition. More paste just masks the issue.
Professional help for ill-fitting dentures. One last thing. What about helping someone who physically struggles to brush, like due to arthritis?
Adaptive aids can make a huge difference. You can easily modify a standard toothbrush handle, wrap it with gauze or tape to make it thicker, push the handle into a foam hair curler or a rubber ball, even attach it to a wider strap handle. Anything to make the grip easier can help maintain independence.
Great practical tips. Okay, could you maybe summarize the absolute must-know points from this deep dive for us?
Sure, I think the big takeaways are, first, recognize the fragility. Aging skin and oral tissues are just fundamentally more vulnerable. They're also key indicators of overall health. Look closely. Second, assessment isn't optional, it's mandatory. Use those risk scales like Braden or Norton consistently, and remember the specific techniques like palpation for dark skin assessment.
Mm-hmm.
Third, interventions need to be specific and sometimes counterintuitive. Things like the 30-degree lateral turn, avoiding alcohol lotions, and absolutely not massaging reddened areas. And fourth, oral care is not an afterthought. It's essential, linked to systemic health, and requires proper technique. Toothbrushes matter. Diligent care prevents pain, infection, and serious complications.
That's a fantastic summary. It's really striking that some experts say you can judge the quality of care in a facility just by looking inside residents' mouths. Thinking about that, how the state of that thin oral tissue, just like the fragile skin, reflects the overall attention to detail and care, how does recognizing that vulnerability maybe shift your priorities when you're providing care, no matter the setting? Something to definitely mull over. Thank you so much for joining us today for this deep dive into these geriatric care essentials. We hope this helps you on your learning journey, and we look forward to exploring the next source with you soon.